So it's kind of a fun break or change from our typical seminars, which are usually a focus on a researcher practitioner partnership that's ongoing. But we are now in I think it's our fourth time soliciting and awarding student research grants. So it feels like a still pretty new program for us. And exciting. Shelby and I are just actually now reviewing the latest batch of applicants, and it's just so fun to have the opportunity to give out these student research awards and learn about what students are doing across the region. So yeah, we'll continue doing this every 6 months with like a year delay. So students apply, they have a year for their projects, and then we highlight their work. And then just a few announcements about upcoming seminars. We're finalizing our January seminar, but it'll focus on older adult falls and mobile health interventions related to older adults. Our February seminar will focus on child passenger safety. So those dates and times and speaker bios are all being finalized, and those flyers will be coming out soon to our newsletter that Shelby runs. And if any of you are not on that, if you can, welcome to send me an email or Shelby an email, and we can get you added to the listserv so you can find out about those upcoming events and all the other opportunities that we have. Okay, anything else I should announce, Shelby? So that's...
Nope, I think you're good.
Okay, all right. So what we'll do, Kenzie, I'll just say, a couple words, but please feel free to introduce yourself in more detail. And I think we asked students to prepare not a very long presentation, 15 minutes or less about the project that you've been working on. And we're happy to get to know your work. So Kenzie Campbell, master's student and MPH student at Boise State University. So we're especially thrilled to have an out-of-state guest on this call because this student grant program is supposed to or is available to all students in injury prevention in the Mountain West region. So glad to have some representation from out of state. And Kenzie's project focuses on suicide prevention among adolescent girls. And so with that, I'll turn it over to you, Kenzie. You can share slides and tell us a little bit more about what you've been thinking about.
Thank you. Perfect. So let me just make sure I have everything set up. Okay. So yes, my name is Kenzie Campbell, and I am in Boise, Idaho. I was actually born here. I went to Salt Lake City, Utah, a college there for my undergrad, and then I'm back here for my master's program, which feels right. And it's been a really great adventure for me this last year. And I will graduate hopefully in May 2023 with my master's of public health. So yes, my project was on specifically, I'm interested in protective factors and risk factors for young people, especially around suicide prevention, depression, and anxiety. So I'm interested in researching with some of my great mentors I've met, what are some of the causes for these increasing suicide rates, increasing depression rates, and increasing anxiety rates for youth in our communities. But yeah, I wanted to share a little bit more about me. And like I said, I'm second year Master's of Public Health student. I have a big interest in adolescent health, and this project kind of jump-started that for me. And so I've been able to snowball into a couple of other projects that I'll share a little bit about in the next couple of slides. And then I just also got a full-time staff position at BroncoFit, which is the health and wellness, thank you, it's a health and wellness office on our campus. So I will be helping with sexual health and healthy relationships programming for our undergrad students, and trying to arm them with safer sex and safe relationship tools to make our campus hopefully a little bit of a safer place. And then I am also interested in mountain biking and hiking with my dog Luna. She's there in the picture. And then Idaho's many marvels. Hopefully people will get a chance to come and visit, or they have visited, but there's a lot of great things here, a lot of great wineries, mountains, skiing, whatever you want, you can kind of get here, similar to Colorado, I think. And so I wanted to just kind of frame my project a little bit and what initially got me questioning or interested in what data might be available to answer some questions that I came up with. So one thing that we're seeing that's well documented is an increase in suicidality or suicidal ideation. You often hear those kind of going back and forth as the same idea. So I might as well. But yeah, so suicidality in adolescents, 10 to 19 years of age, we're seeing an increase overall for that demographic, but we're seeing an even bigger skyrocket for minority youth. So that's both racial minority youth and especially racial minority girls. And we know as well that depression and anxiety are a good predictor that goes along with suicidality often. So when I was looking at studying this, it made sense to kind of look at those rates as well in the data. And then one thing that I found really interesting that is pretty well documented is that for our LGBTQ youth, a protective adult makes a huge difference, like a demonstrated reduction in suicide risk for youth. So we know that there are some really strong protective factors or, some factors that we can study or we can learn more about that does impact and reduce suicide, depression, and anxiety. So I wondered if there would be a similar factor for racial minority youth as well. So that kind of led me to my question of what role do adults at school in particular play in youth mental health outcomes? And this is sort of a hot topic for Idaho right now. Our state is very involved in our K through 12 education, kind of dictating exactly what teachers can talk about and how they can support students. So this is will hopefully be impactful research to share with our legislators about how important it is to talk about mental health and things like that. So I use secondary data analysis. My research mentor, Dr. Megan Smith, she was previously at a university in West Virginia and provided, once I talked to her about my interest, she provided some great collection of data that we could kind of ask our questions about and see, kind of look further in the data to see if there were some possible significant results. So the data that we used was a sample of 3,024 adolescents. So they were 12 to 18 years of age with a 79% response rate. It was collected in 2021. So there also was some good questions asked about COVID-19 and the impact there, which is really helpful when we're talking about mental health because likely any data collected during that time will really potentially influence some of your results and some of the reasons why those rates are skyrocketing. One thing that the data included that was part of my interest was a scale about protective adults at school. So it asked students questions like to what degree they agree, if they feel like the adults at my school care about me, if they feel like the adults at my school believe I can make the world a better place. And this was these are just two examples of a 10-item scale that was used. And then we also screened for suicidality, depression through a clinical scale, and anxiety through a clinical scale that's often used, like that kids would be asked at a doctor's office. And so I performed some data analysis. I did a factorial ANOVA, which I had learned about in my master's program, and was able to put that to use to answer my research question. I had originally been interested in writing a paper, which we're still working on, but a lot of other projects with my mentor has kind of come up. So specifically the ways that I was able to fulfill my work for this grant was that I was able to go to a conference to present about this data and these great results that I found. And so I went to the Society for Public Health Education Advocacy Conference, they call themselves SOPHE, in Washington, D.C. And it was in October of this year. And I was able to do an oral session. So I had 10 minutes to present about my research and my data and the implications, especially in today's day and age and related to advocacy, because that's really what they were interested in. And that's one of my big interests. I titled the presentation Impacts of Protective Adults on Mental Health Outcomes for Racial Minority Adolescents. And I was able to share that the absence of a protective adult does predict high suicide rates, high depression rates as well. It didn't for anxiety, which was interesting, but so we did see that protective adults potentially have a huge role to play in youth suicide prevention at schools, especially since they spend the majority of their day in the week at school. So it's just an important kind of point to know for advocacy implications. I was asked as well to talk a little bit about some successes and challenges, and I had a lot of great successes or great things that came from this project and this grant. So again, we're working on an opportunity for publication in 2023, which was a big goal of mine because I might have some interest in pursuing a doctorate degree. So that will help me in that journey. And then this really has become, working with my professor, and she's the person on the left, this really has become a great stepping stone for community work. So I have a little logo called Communities for Youth, and we were able to start an organization in Idaho, the first that Idaho has, if you can believe it, that is working on improving youth mental health, just because Idaho is looking really worrisome with our numbers lately. So this work that I was able to do via this grant from the Injury and Violence Prevention Center allowed me to kind of find that passion, that interest, and pursue it specifically in my community, which has been really good. We've been up north, so we've been in Coeur d'Alene working on youth mental health, and all east and west of Idaho, a couple of small rural towns, and then of course in the greater Boise area where a lot of our population is. It also increased my interest for data. So data is no longer just a boring thing to me anymore, but I have really enjoyed getting to dive into it a little bit and kind of get your curiosities answered just by a great data set. If you know how to run a statistical test, you can really see if the things that the research suggests might be related is related in your data. And I think that that's a great tool to have gained and to learned. So I enjoyed that. Some of the challenges though, just mentorship challenges, people are so busy, and that's kind of why our paper was put on hold. There's just so much great work to do, especially with when you're in a highly involved program or center, for example. Everybody's got their hands in a lot of things, so it can be difficult to also be myself to focus on one thing when there are so many other great opportunities. And then funding, of course, going to conferences is quite expensive, and sharing your work is quite expensive. So this grant has helped a lot with that, and some things on Boise State's campus. But I would say that might be some of the biggest challenges for my future work as well. And yeah, just a thank you to the Injury and Violence Prevention Center for the opportunity and the ability for me to fund this work. And then my contact information is at the bottom in case anybody has any questions about the project.
Thank you so much. We probably have time for just a couple questions before we move to Kate. And I'll start by, it's not, I have so many comments rather than questions, but your work just feels a lot like what we're doing here in Colorado with our youth surveillance system that's been part of the Youth Risk Behavior Survey, the Healthy Kids Colorado survey. There's just been such a focus in recent years on protective factors and resilience and the important role of parents. And I have to say, we're seeing certainly the same relationships there of parents just being so influential. And I guess it makes me think about you moving to the college age population and how that might change a little bit with, I don't know how many of students are still living at home, but thinking about parents having a less influential role and how we still help young adults, find supportive people in their life when they're in crisis or feeling depressed. And yeah.
So true. Yes. I'm so interested in learning how, as students age out of being an adolescent to a young adult, how those might change, those protective factors. And I totally think it's there's a big gap in the research for folks to dive into that too. So that will be interesting. I think that there will be some interesting differences. So yeah, that's cool as well that I didn't know that you folks have that big initiative in Colorado. That's helpful.
Yeah, I don't think we've really done a lot in terms of peer-reviewed publications, but certainly in terms of the products that we release to the public, like infographics, that's I think a key way that we frame them is it's both to have kind of a positive message rather than like a risk framing for youth, and just thinking, and it also, I mean, another kind of consideration is, the data are collected, our data are collected in schools, but I think it puts too much of the burden on schools, if you talk about all the things that have to be done in schools, because it's a community that needs to, and families that need to support kids as well. And framing it about protective adults really puts it across the range of contexts that students interact.
Totally.
Are there any questions for Kenzie? I do want to say, if it's ever of help to you, we're in touch with our campus, maybe parallel group called the Phoenix Center. It does a lot of sexual violence prevention, and if it could ever be in help to connect you to another campus. And also we have a great DR page program too for when you
go. Oh, good to know. Yes, I will reach out to you about that. That would be so helpful, as I just started this role. There's a bit of framework that was provided, but there's really a lot to research and see what other campuses are doing. So I will totally reach out to you about that. Thank you. Thank you all for listening as well.
Yeah. All right. Kate, do you want to go next?
Yes, let me pull it up.
And Dottie, thanks for joining. We'll check on your connection after this, and hopefully you'll be good to screen share.
Okay, is that showing up now?
Yep, looks great.
Okay, great. Okay, well, thank you for giving me this opportunity to present some of my ongoing work in our lab. We are changing gears a little bit from the last presentation, and we're moving into sports injuries versus suicide prevention. So a little bit of a different topic. Also a little bit about me. I'm a physical therapist, so a lot of my research questions are driven by my physical therapy practice. So some of what we'll be talking today, I'll try not to get too into the weeds on PT type things, but that is informing a lot of my research. And just a big thank you to my mentors and committee members. I don't think any of them were able to join today, but this is part of my dissertation work for my PhD project, looking at subsequent injuries after concussion. So I am fortunate to have these great mentors on my team. So we'll be talking a lot today about concussion, and I'll just start with a brief overview of what a concussion is. It is a traumatic brain injury that results in impaired neurological function, typically cognitive and motor deficits that are generally short-lived. Concussions are considered a major public health concern, and there's an estimated 3 million concussions that happen annually in the US. And in adolescents, which is where we focus our research, approximately 1 in 5 have sustained at least one concussion due to sports participation. And these numbers are likely underestimated due to improper diagnosis or individuals just not seeking care for a concussion. So a concussion can be caused by either direct or indirect force to the brain. So that can be a blow to the head, or it can be force to the body that transfers up through the neck to the head. And there's lots of different symptoms that can result from a concussion, and they can touch a pretty broad area of our lives. So physical, cognitive, emotional, and sleep. So what specifically we are interested in looking at with our research is following concussion, there is a 2 to 3 times increased risk of a subsequent injury when an athlete returns to sport. This exists after clinical recovery, so they are no longer experiencing any symptoms and they have passed all of the return to play protocols. But clearly there's some dysfunction that still exists that's not being detected with our current protocols. And this injury risk has been observed up to 3 years after concussion. And these subsequent injuries can be musculoskeletal injuries, so anything from a minor ankle sprain to a surgical ACL tear, or a subsequent concussion. And this risk has been observed in athletes of all levels, from youth athletes all the way up to professionals. It's been observed in military members and also the general population. And while there are theories for why this risk exists, such as decreased neuromuscular control that lingers after a concussion, nothing has been proven. So further research is needed to identify what factors are contributing to this increased injury risk. One lens that we're going to be looking through today is socioeconomic status. Individuals of lower socioeconomic status may be more vulnerable to poor outcomes following concussion due to a variety of reasons. They can have underlying undiagnosed health conditions. They can be less likely to be diagnosed with a concussion if they go to the emergency department, and they are less likely to access high quality and specialty concussion care. Also, this will become important, and we'll talk about why on the next slide, but people of lower socioeconomic status have been found to have higher rates of visual impairment at baseline, so in their preseason testing, and we'll talk about why that is important for this project. Another lens that we're going to be looking through is through these 3 main neurological systems that can be affected after concussion. So we're not going to get too in depth on this, so we'll keep this pretty broad, but we've got our eyes, our ears, and our neck. And all 3 of those systems have to communicate together to give us information about our balance, where we are in space, and help us react appropriately to what's happening around us. And the overlap between these systems becomes really important when we think about different reflexes that help us maintain our gaze and our balance and our posture. So where we want to be operating is right here in the middle, where all 3 systems are giving the same information to our brain. If any one system is off, that can lead to balance impairments or disorientation, dizziness, things that we think could potentially lead to an increased risk of injury. So what we know from previous literature is that the visual system and the vestibular system in people with lower socioeconomic status at baseline, so pre-concussion, they can have deficits in these 2 systems. So that could potentially be predisposing them to poor outcomes when they are participating in their sports. So what we want to understand is, do these similar deficits exist in the cervical spine? That has not been looked at, so that is one area that we are investigating. So this is especially important for athletes. Athletes need all 3 of these systems functioning and communicating normally. So after a concussion, if an athlete returns to sport, especially in a visually stimulating and dynamic, busy environment, and they have undetected dysfunction that exists, they may experience impaired spatial orientation, balance, and gaze stability. And this can potentially increase their vulnerability to subsequent injury. So for aim 1 of this study, what we want to understand is, first, is there an association between cervical spine dysfunction and socioeconomic status? So that is aim 1. Aim 2 is moving into looking at the subsequent injury that we talked about at the beginning. So why people are cleared to return to play, but are experiencing higher rates of injury after return to play. So what we want to understand here is twofold. Is there any predictive ability of cervical spine dysfunction or socioeconomic status in predicting subsequent injury after return to play? So for this study, our study population is adolescent athletes, ages 13 to 18 years of age, within 18 days of concussion. So we see them initially within that 18 days, and we do a battery of assessments, including their intake, medical history, demographic information, their measure of socioeconomic status, which we'll talk about on the next slide. And then we do some specific cervical spine testing. Then they are cleared for return to play by their physician, and we monitor them for 3 months after they return to play. And we are sending out surveys about any injuries they've sustained and exposures to sports, so games, practices, and competitions. Our measure of socioeconomic status is the Family Affluence Scale, and this is a 6-item scale that has been validated among adolescents, and it uses an assets approach. So what types of things do their families own, rather than zip code or household income. So the total score range on this is from 0 to 13, with higher scores suggesting higher family affluence. Then our monthly injury surveys. This is just a short clip of the questions that they're asked. We do get more details than this, but we're really asking about any injuries they've sustained, location on their body, where the injury occurred, who diagnosed it, how much time did they lose from their sport. So we're really getting lots of information about any injuries that they do sustain. And then our measures of cervical spine function. I'm not going to go into too much detail here, but I have information if anyone's really interested in what we're looking at with the cervical spine. But we've got a cervical spine MRI that gives us measures of muscle volume in the neck, and also fatty infiltrate in those muscles. So how much fat is contained within that muscle volume. And then we do a proprioceptive test of the neck as well. Okay, so we're not complete yet. We have, our study is still ongoing. We have 14 participants enrolled, and they are somewhere within that 90-day follow-up. Mean age of the participants is 15.6 years, and they are typically, or on average, their initial assessment was within 11 days of concussion. So what we can see from this table is we do not have a whole lot of racial or ethnic diversity in our sample, with about 70% of our sample to date being white individuals. So this will, we'll be talking about the challenges we've been having with this study. But that is the diversity of our sample. And then looking at our distribution of family affluence scale scores. Remember, it's 0 to 13. 13 is the highest. Obviously, we are very skewed toward the higher socioeconomic status end of the spectrum. So we are missing a whole range of socioeconomic status information. So as we continue to collect data and increase our sample size, we're really hoping to get a better spread of this data to better be able to answer our research question. Because currently we can't really answer the questions that we set out to answer with this sample. So as we continue our work, this has brought, we're having lots of conversations in our lab about, okay, what do we do about this? So we're seeing that we're not really recruiting a diverse sample. Where do we go from here? So we are discussing how to expand our recruitment strategies. Right now, our primary pathway is through the Children's Hospital Sports Medicine Clinic. So it's a specialty care center, which just tends to see a more white and affluent population. So we are trying to expand that to include a referral pathway from the emergency department and urgent care centers, as well as athletic trainers who work directly in the schools, because they have access to all of the athletes that are on their team. So if we can we're in conversation with some of the local athletic trainers to see how we can expand our recruitment through those avenues. And then this has also started a conversation in our lab about, okay, so our research is not necessarily representative. What does the rest of concussion research look like? And who are we who are we doing our studies on and basing return to play protocol information on? So currently in our lab, our other PhD student is leading a systematic review, looking at the racial and ethnic diversity of the studies that inform our concussion care protocols. So we're trying to better understand how are we basing our decisions, and is that on a representative sample? So that's some of the future and ongoing work in our lab. So stay tuned, because this project is ongoing, and I look forward to what we find in the next couple of years. So I would just like to acknowledge and thank the Injury and Violence Prevention Center for funding this work in the beginning stages. And I'd also like to thank my lab pictured here, because without them, none of this would be happening. So thank you all very much for listening, and I'm happy to take any questions.
Yeah, thanks, Kate. I have spent some time around sports injury and concussion researchers, and I had not heard this this finding about this association with re-injury, and it seems like there's a lot more work to be done if that's what's being observed, and it kind of makes sense actually from just anecdotes and things that we hear in the news with professional athletes and that sort of thing. I have one comment, and then happy to have other folks give questions. Oh shoot, I just lost what my thought was. Oh, all right. Well, I'll remember it, but if anyone has any questions, please jump in now.
I would like to ask a question.
Sure.
Just because your study was lacking diversity. I know that even if increasing recruitment strategies, if you had ever thought of specifically asking American Indian Alaska Natives to join, just because sometimes it's really hard to get their representation in studies. So I just was wondering if you had thought about that at all.
We are open to anything. So if you have specific ideas on how to reach that population, I would be very happy to take that back to the lab. The ideas that I presented are what we've talked about and ways that we can try to increase our samples to be more representative of the general population. But if you have specific ideas on how to reach that specific population, totally open to it.
I guess going along that same line, excellent presentation. Have you been in contact with any school districts or, for example, I don't know if I missed that, but say if there are any local Aurora schools or anything like that who may want to have, be a part of this data and also have opportunities for even kids to be involved?
Yeah, thanks for that question. So the way we're going about that is through the athletic trainer network that we have access to. So I believe at least one of the trainers that we're working with is specific to the Aurora school district. So that is how we're trying to get into the schools. But yes, we do think that having a presence in the schools would likely increase our access to a more diverse population. And again, if you have other ideas about how to go about that, let me know.
Hello, I have a question. Who is the primary funder for the data collection from your mentor team?
Sorry, did you say who's the primary funder?
Yeah.
We have funding through the Thai Foundation and through the NIH. My mentor has an R01 through the NIH. So those are the two main studies that I'm working on are through those two mechanisms.
Thank you. Great to know.
Thanks, Kate. I remembered my comment, which now feels anticlimactic, but I just in this past semester, I've been aware of to students who suffered concussions, and I was just really just, you know, they really suffered like long-lasting effects. It really impacted their learning, and I sort of, I guess I had an underappreciation for how disruptive and impactful a concussion can be. And it's just really, you know, when it comes close to home, or, you know, it happens someone close to you, you start to have this appreciation for this. And I just want to echo how important this research is.
Yeah, thanks for that. That one of my dissertation aims is actually in adults with a concussion history, trying to understand what deficits still exist after they're considered to be clinically recovered. But we're trying to really get to the bottom of, okay, because we think of concussions as being pretty short term, but what is really existing up to that 3-year mark? So trying to get a better understanding of what's happening there.
Sure. Well, thanks. Well, we'll move to our last presenter. Yeah, I'm glad I heard you had some technical difficulties, so I'm glad you're able to join. And Dorothy Stearns is a student here at the University of Colorado School of Medicine. So you can introduce yourself and your topic.
Sure. And I graduated this May, so now I am a doctor. So yeah,
Yay.
yeah. So
See
exciting.
those credentials.
Shout out to the, yeah. I just put them on there, just like, I guess, now I do that. All right. Well, again, hello everyone. Thank you for allowing me to have the opportunity to present today. And also thank you so much for this opportunity to have this grant, which was really helpful for me to be able to attend a surgery conference I guess this year. Wow, January. So to introduce myself, I was a medical student last year, and now I've graduated. And now I'm currently at The Ohio State University as a general surgery resident. And I think it's super important to be able to discuss injury and violence prevention, especially where I'm at now, because we actually have a prison unit at my hospital where we actively work with inmates. So I think this research has actually been very valuable for me, and I'm interested in continuing this work at my new institution. So with all that being said, my presentation is sex differences in violent death during incarceration and legal intervention. Okay. Disclosures, as stated, I am a recipient of the grant that was provided. So I want to say again, thank you, and that I was able to fund my experience at the Academic Clinical Congress, which is a national surgery meeting, and I was able to present there. So thank you again. All right, to start off, just an important note or statistic is that almost all United States Department of Corrections have reported an increase in prisoner numbers in recent years, with poor outcomes such as overcrowding in short-staffed prisons. More inmates may engage in increased conflict and interaction with prison staff and fellow inmates. For example, say if there are gangs or turf wars, this could potentially result in violent behavior among a large population of those inmates living in close proximity with each other. This could be a concern for both inmates as well as prison officials and other staff members helping out at the prison. Again, this could lead to decreased resources for these prisons, lack of access to medical care, lack of opportunities, and then also, again, these dynamic social structures. This also can influence both homicidal and suicidal behaviors, and there's been extensive research and literature seeing how increasing number within a small prison can lead to increased conflict. Of note, also bullying and violent inmate conflict have been associated with suicide completion, which is a part of my project that I've explored. And then inmates can also be subjected to high rates of victimization, which can include physical, sexual, and emotional as well. Another data note is suicide in prison ranks as the second leading cause of death. And this is behind natural causes. The U.S. prison system is disproportionately male, so that in terms of statistics states that most suicides in prison involve male inmates. However, there's a growing population of female inmates, and this has dramatically increased over time. And now there are a lot of researchers exploring the relationship of gender and sex and suicide in prison. And just to give a disclaimer for this particular data set, it doesn't explore gender identity, it identifies sex, and I can discuss that as a limitation later on in my project. Just because the relationship of gender identity, sexual identity, and other identity groups can be very nuanced. So that's something to consider. So female inmates have unique challenges and complex prison experiences that can also impact violent or self-injurious behavior. In some studies, they've seen that female inmates report higher levels of emotional distress when they're entering the prison compared to their male counterparts. And they've also seen that they may enter prison more impoverished or more often impoverished. Prior victims of trauma have higher rates of substance and alcohol use disorder, and also poor markers of physical health. So with this in mind, my team and I looked to further investigate these specific factors within each of these populations, the male and female inmate population, to assess and prevent violence, injury, and deaths among those who are incarcerated. So with this, my team has access to the National Violent Death Reporting System, which is a database that is provided from the Centers for Disease Control and Prevention. So this particular data set has thousands and thousands of incident reports, which are based upon, there'll be like an event excuse me, an incident, and it'll have different victims involved in these incidents. And with that, they'll have the location of the injury, they'll have different demographic factors such as income, age, race, as best as possible that they collect with each of these. Granted, a lot of these are from death certificates, law enforcement reports, sometimes coroner reports, and even also sometimes from family or other people who are involved in the incident. So again, this is not entirely comprehensive, but it is a start to be able to analyze violent death. And it is an attempt to make sure that we can try to assess this and at least gather some information. All right, so again, just to discuss, my team, we analyzed demographic characteristics of these deaths occurring during incarceration and legal intervention, which is the process by which that occurs prior to someone getting incarcerated. And we did this by sex to assess if there was a significant difference in the circumstances of mortality. So sex was identified as binary in this data set by male or female. Victims were either in custody, in the process of custody, or in prison, as I stated. And then the circumstances of mortality can include homicide, suicide, unclear intent, because sometimes they weren't able to figure that out with each incident. And then we also analyze aspects of their mental health, which occasionally are recorded. And if they've ever had treatment in the past, if they've ever had previous suicide attempts, and also if they have comorbid substance use or alcohol use disorder. We also were able to parse out if they've had existing treatment. And so we were able to analyze whether or not that had a role. And then for this, I used SAS 9.4 statistical software and used chi-square test with an alpha of 0.05 to test for significance. And this data was collected and used from 2003 to 2019. So this is just the general demographics that we collected. So we had, when we collected and parsed out inmates, which there's a way to do that, we were able to collect around 4,400 inmate profiles. And the average age between the female and male inmate population was comparable. And then for race, the majority for both populations were white, non-Hispanic. However, you can see here that for Black or African Americans, males accounted for a higher percentage within the incarcerated population compared to females, compared to Black females, which is representative of the mass incarceration of Black individuals in America. So I thought that was a very important note. And then you can also see additional racial and ethnic communities. Also, you can see that educational level wise, the highest percentage was among high school graduates. And these were somewhat comparable between females and males. And another important note is that for those who had substance use disorder or problems, females had, they accounted for, that among females, 41% of them had a substance use problem compared to males, which only 19.9% of them had a documented substance use problem. And that's a huge difference. So it's important to you can see it's somewhat comparable for alcohol use, but the substance use one is very, to me, it was a very glaring observation. My second table discusses more of like the death circumstances. So for homicide, males accounted for, males in terms of, comparing females to males, males had more incidents of homicide compared to females. You can see for females, there were only 6 versus males that accounted for 594. And for both communities or for both populations, suicide occurred the most frequently, and it occurred more often in the female inmate population when compared to males, which is around like 78%. The primary mechanism for both communities was hanging, strangulation, or suffocation, followed by, for females, poisoning. And another important note for mental health problems, among females, approximately 44% of them had mental health problems when compared to males who had approximately 26.3. And also you can see in terms of current mental health treatment, of that same percentage, 28.8% compared to males, which was 16.1%. And I actually have a table that that I'll show next that goes deeper into this. All right, so as discussed, so this is a subset of those who had the pre-existing mental health conditions, which accounted for around like 1,200 inmates. Of the ones that had the mental health issues, for females, approximately 63.2% were currently getting mental health treatment, which is comparable between both females and males. And a history of mental health treatment around, for females, 79.1% had a history compared to 73% for males, which the p-value is not significant, but these are just important to note that at least majority of them have had some level of mental health treatment, but not enough. So in conclusion, there are risk factors that may have sex-based differences. So risk reduction may have targeted strategies. Again, female inmates, there's a higher percentage of suicide or intentional self-harm in that population compared to males, although both have majority of them for violent death committing suicide. And then compared to males, they had a higher percentage of mental health conditions and substance use disorder. For male inmates, they do represent the majority of homicide victims. And then another important note, as discussed, that among the population of inmates, Black males accounted for a higher percentage of those male violent deaths, and in comparison, around twice the percentage of Black females, Black female inmates. Some limitations with this data set, in terms of the National Violent Death Reporting System, we do not have the true denominator of inmates in this database. So some of these statistics, obviously, we might be missing more patients or more inmates that we weren't able to account for. And also, as discussed earlier, because sex is identified as binary and it also doesn't have gender identity, it also doesn't have sexual orientation. These can all add nuanced experiences to the inmate experience. And so we kind of have to take this data with some perspective that it may not be encompassing each inmate's experience in the prison. So the implications are that the prevalence of female inmate mental health treatment could either be the result of increased efforts to prevent suicide or interventions, or that currently those who are, to prevent suicide with their current treatment may be ineffective. And then also understanding psychiatric and substance use disorders is necessary for appropriate intervention, especially female inmates. My next steps, there are other databases outside of the National Violent Death Reporting System. Specifically, there's one called the Healthcare Costs and Utilization Project, which has millions of patient files. However, I'm not sure necessarily if they have inmate level data. That's something I would like to look into, or other databases, just because some of those larger databases might have additional characteristics that might be worth going into. There's also some inmate level data from the Bureau of the Bureau of Justice. So I may want to look into that too. Yeah. So acknowledgements. My mentor is Dr. Villopoulos, who is a trauma surgeon at University of Colorado. She has mentored a lot of medical students who are interested in violence prevention. And so I'm deeply grateful for her for providing me with this opportunity. I also am with other researchers as well. Dr. Myers, Dr. Carmichael, and also Dr. Moore, who is now a resident as well. So thank you. With that, I'm welcome to questions.
Great, and thank you so much for that very impactful presentation. And we're just at the top of the hour, but we do have a question from Barb Gabella. Could the sex-specific results for mental health be confounded by sex differences in seeking healthcare? Yeah, with women, seeking healthcare at higher rates, leading to differences in diagnosis of the substance use or mental health concerns. Yeah. Yeah, I don't have, yeah.
Was that?
Oh, sorry.
Was that a question? I might have
yeah,
missed it.
well, yeah, I mean, I don't know if it's a question that can be answered. Differences in health, in seeking healthcare, if we know that there are sex differences and gender differences in that, could that lead to differences in the diagnosis, because there's not essentially, maybe universal screening for that.
Exactly. Exactly. And also some of the, I'm very curious about the prison level assessment of mental health, or whether or not these are documented when they are admitted or not admitted. Well, now I'm a doctor, so I say admitted, but like when they are sentenced to prison. And I wonder whether or not they just do screenings, and if the screening pools are different. I know there is research on how they screen, but that's something to look into as well.
Yeah.
I'm the one who did the statistics. Yeah. My MPH is in environmental health, and I studied epidemiology, so I'm the statistician. Yeah. Sorry, I saw someone in the chat.
Do you think you'll be publishing this? Thanks, Kate.
Yes, actually, I'm in the process of publishing this. I'm behind, obviously, since I'm in residency, but I actually have presented this and I submitted my manuscript. I just need to follow up with my team.
Good, wonderful.
Yeah.
Well, thanks. We're at the hour, so we'll end. But Kenzie and Dottie, and I'll let Kate know, please feel free to put this on your CV as an invited talk. And we're so glad that you were able to join us today and excited about your progress in your careers. So, thank you. And with that,
Awesome.
we'll end. Take care, everyone. Okay. Bye.